And
Hello.
I'll present the slide deck here, Anne, if you just give me a sec.
Okay.
Okay. And the rest of the team, you can monitor the people coming in because I will not be able to see here. Okay. Can everyone see the slide deck?
Yep.
Yep.
Excellent.
Looks good.
Okay, Anne, you're on.
Okay, thank you, Kelly. Hello, everyone, and welcome to our March Advisory Council meeting. It's nice of you to join us all this morning. It's pretty early. First thing I'd like to do is, I think since I haven't seen these people coming on, I'll just announce 2 new members. We have 2 new members to our AAC. One is Jamila Abu Du Kadir. I practiced that, apparently it didn't help. And the next one is Joseph Buhane. Jamila is an RT and Joseph worked with asthma at St. Paul College for quite a few years, but I'll let them do their own intros when they get here. Kelly sent out the bio sketches yesterday. So we're gonna dispense with introductions to save some time at this meeting. So this is our agenda for today. We're going to provide a quick high-level overview of the asthma strategic framework. We're going to demonstrate the interactive framework, and then we're going to use breakout rooms to talk about opportunities and challenges to implement the framework. And we'll attempt to have each AAC member identify a few steps they can take to help move the framework forward.
And I just wanted to step in here. I know that Susan Ross had an announcement also to share today.
Yeah, I put that in my notes, but my notes have apparently disappeared. So Susan's announcement today. Thank you, Kelly.
Yeah, no problem.
Just want to let y'all know that I am retiring. My last day is actually June 1st, or yeah, 1st, but technically I'll be out of the office for the most part, starting June 12th. I'll be peeking in and out in May, just picking up notes and clearing out emails and doing a few other things. I'll be taking vacation during that month. So I am retiring for all the reasons that everybody else leaves grandchildren they'd like to see, and the chance to travel before I'm too old to travel, etc. I wish I could was on vacation right now because my daughter needs me, but yeah, it has been an honor and a joy and an amazing adventure working with all of you, getting to know you, and I'll stop because then I'll start crying.
Thanks, Sue. Well, we'll miss you dearly, and we do appreciate all the wonderful work that you've done for the asthma program over the last, 10 years? Is that correct?
20.
Yeah, 20 years. Okay. Well, I've worked with you for 10 years. I guess that's why. So, all right.
So,
thank you so much.
Susan, I just want to tell you as you're departing, you had sent me an email about the coach's clipboard asthma training, which you developed, which I think is wonderful, and you get all the credit for that. I have to tell you that I have a very good friend of mine who's way big up there in the Boy Scouts. And he's a pediatric cardiologist in Morgantown, West Virginia, and has actually been the medical person in charge of their national jamboree type thing. And I mentioned to him this coach's clipboard, and he's actually going to bring this to the Boy Scouts of America, the Boy Scouts of America. And I'm also talking to the YMCA about at least the Y of the North of bringing this coach's clipboard training to the Y. So I wasn't sure if we would have time for any kind of updates or anything like that, but I wanted to be sure that you knew that I was super excited. He was super enthusiastic about that. And so those are 2 potentially really big organizations that are hopefully going to adopt this asthma training for people who work with youth doing activities.
Oh, thank you, Gail. I developed the first one way back in 2006, but Kelly and I and the whole team worked on the next two versions. At
The
that's
athletes and asthma, yeah, the
Yeah,
King
athletes
Coaches
and asthma
course.
coaches,
Hmm.
the next version of it. But that's wow. Thank you for
Thanks,
sharing
Gail,
that.
for
That's
doing that.
fabulous.
Appreciate
That
that.
So
gonna
when
be a
I
rock to
do
her.
when I forward him the information, will it be called Athletes and Asthma?
We
Yeah,
still
Gail, I
have.
can connect with you on that if you want. Actually, I was the one that sent the email
Oh, okay.
that asked you to maybe see if the Y would be interested in actually
Right. No, I do
introducing
remember
that.
that. I do
Yeah,
remember that, Kelly. And I just, again, I remember when Susan first, way back,
yeah.
did the coach's clipboard. But yeah, if you could, I do still have your email with a little flag on it. So I don't want to interrupt the agenda, but I
Yeah.
just wanted to just acknowledge that to Susan, since that was her one of her brainchilds. Um, and just to know that your baby is growing and getting out there in the world.
Thank you, Gail. I thank you so much.
Thanks,
Speechless.
Gail.
Thank
Maybe
you.
Sue and I can connect with you and before she heads out here and we can talk more about that.
Awesome. Thank you so
All
much.
right, thanks. All right, Anne, back to you. I'm going to advance the next slide unless you have more that you'd like to talk about on this meeting objectives and format slide, or do you want me to advance
Uh,
for you?
You can advance. I would just like to, again, say thank you to Gail and say that is exactly what we're looking for in the breakout rooms at our next, our next part of this meeting. But first, an overview of the strategic framework. Next slide, please. So this is just a brief overview of sort of the facts that are in there and the goals and action steps from our framework. Right now, as far as we can tell, approximately 431,525 Minnesotans currently have asthma. And this is different than the number in the state plan because the data used to create the plan is now 1 to 2 years old. So we're still growing in people with asthma. So just for people who have not been involved in asthma for their entire lives, national surveys generally collect information about asthma prevalence in two ways. One is whether a person currently has asthma, and the other is whether a person has ever been told by a healthcare provider that they have asthma. If we look at the number of Minnesotans who've been told that they ever have asthma, then the number, not surprisingly, is larger, 672,969. So that's significantly larger and a little more than maybe 10% of Minnesota's population right now. So when you consider the people who are indirectly affected by asthma, so families, caregivers, teachers, friends, it's a whole lot longer than that. And that is exactly why we need this plan to kind of continue working on making life better for these people and their caretakers. So poorly controlled asthma can lead to missed school days. In 2019, approximately 24% of children with asthma in Minnesota missed schools. Missed school days are associated with decreased academic performance, which can lead to lifelong deficits in learning and in earning. And then in 2019, also over 16% of adults with asthma reported missing work or being unable to carry out their usual activities, which can result in decreased income for their families and also lower productivity for their employers. So I see that Kelly is already a couple slides ahead of me.
Sorry, Anne. Tell me when you want me to advance the slide. I'm on slide 6 now.
Right. So I would like you to be on the next slide now.
All right. Just tell me when you want to go to the next slide.
I will. So this is a slide showing asthma prevalence both in the United States and in Minnesota. And as you can see, Minnesota's rates for both children and adults for current asthma are lower than the national average. In fact, overall, Minnesota ranks as having some of the lowest asthma rates in the nation. So next slide, please. So this shows a racial breakdown of prevalence. for Minnesota and the US. And once again, the green bars for Minnesota tend to be lower for both all people and for whites, and also in this graph, Hispanics. But both in Minnesota and across the country, Blacks and Native Americans have higher rates of asthma than whites, Hispanics, and Asians. And while the rates for whites and Hispanics are higher than the national, or sorry, are lower than the national average, the rates for Blacks and Native Americans are much higher than the national average in Minnesota. So next slide. So the national data sets we rely on for prevalence overall don't break down data by country of origin. And our Minnesota student survey does do that breakdown. So here's a slide that Emily Grebner, our student worker, helped put together. And this shows asthma reported by Latino, Hispanic Minnesota students. And you can see that it's very different depending on which country of origin you're from. So keep in mind that these data can't be compared to the BRFAS data because BRFAS data are shown for people reporting current asthma, while these data for students report people who have, or students who've ever been told by a healthcare provider that they have asthma. So we would expect the rates reported in the student data to be higher than the BRFAS data. And as I was saying before, there are large differences within this group that most surveys treat as a monolith. So we go from 12% for students who identified as Ecuadorian, and 27% that are from Puerto Rico that report having ever been told they have asthma. So this compares to only 15% of white students, which is not shown in this graph. But I would say that looking at this graph, we can't really conclude that asthma is not a problem for our Latino and Hispanic populations across the board. Another concern we have about this group of students is that possibly it's underreported due to inadequate access to health care. So next slide. Kelly, thank you.
Yep. Yep.
These graphs show the same data, but one adds, the second graph adds the data from 2020. So when we were looking at the state asthma plan, we had the data through 2019. And as you can see there, we have, I put in the green trend line, which shows that rates for Black Minnesotans are trending downward. But you'll also notice that there's really high variability for the Native Americans in this study, and quite a bit of variability for Blacks in this study. So when we added the 2020 data, you can see what happened to the trend line. It really flattened out, still a little bit downward, but overall, that really encouraging looking downward trend has pretty much been obliterated. So this is a problem when you have data that has high variability year to year. You really can't say a lot about trends until you get quite a few years of data.
Can I ask a question?
Yes.
So, is there a way to validate, and I know this is asthma prevalence just by report, but you know, the Minnesota Community Measures, or the whatever that the upper organization requires clinics to report on asthma control and asthma action plans. And it seems to me that, I mean, there's numbers there, right? They have to say how many kids and adults they're seeing with asthma. right? So we have an asthma registry here at Hennepin, so we know all the people with asthma, so that in our electronic health record, if you have asthma on your problem list, then you have to have this, and I mean, it's just a data collection thing. Is there a way to sort of compare numbers as reported by clinics and to what's self-reported? Would that be something that might give you, and with the realization that a lot of times people don't go to consistent clinics and there's all kinds of criteria for who's doing primary care and all that other junk. But I mean, I'm just wondering if there's a way to compare numbers to get maybe something objective versus self-reported.
There would be if we could get a hold of data from clinics. I mean, it might be just pods of clinics or a few particular clinics. I've asked Minnesota Community Measurement about getting just plain data from them as opposed to what's on their website. And so far, they've basically indicated that they will not give it to me. But if the data that you're talking about are available, I can certainly make a stronger effort to do that.
So, you know, and I'm not going to belabor this. I know Susan has heard this in the past, because I think this is a travesty that the fact that Minnesota Community Measurements is collecting that data is from a mandate from the state. And you are the state health department. And so somehow that seems crazy to me that the health department does not have the asthma program for the Minnesota Department of Health does not have access to data that the state has mandated that clinics report. So I'm going to leave it there. It's political, obviously, but I feel like you need to push this because I think that information is going to be really important for this group. I'll just leave it there. We could talk more offline if you want my opinion.
Gail, I agree. This is Kathy Norleen. My question is, does the data that's collected include race and ethnicity or not? And that kind of is a changing landscape over the years.
So what I would do, Kathleen, is I would look at the Minnesota Community Measures website or the state. It's SQUIRMS. I can't remember what the SQUIRMS stands for, but it's SQUIRMS. But there is several pages of what needs to be reported by whom, and so what data clinics need to collect. I don't know that race is in there, but still, I think if you have an N, right, if you have a number, right, that I think that at least having a denominator is maybe going to be helpful. So
okay.
I could tell you that is available. That is publicly available information.
Yeah. Okay, thanks. I just didn't know if race ethnicity was in there. And okay, another discussion later.
Okay, we do get the SQUIRMS data, but most what I get from that, which is what we've gotten from SQUIRMS for quite a few years, is basically measures of optimal asthma control, risk, and education. So
right, but that's a denominator, and that's what I'm saying. So there is a number of people that they have to. I mean, it's not everybody, but that's a denominator, and I think looking at total numbers of people just with asthma that are being at least that are known by clinics and are being followed by clinics, I think might be important. Again, I'm just responding to your observation that it's inconsistent. The data has been inconsistent because this is self-reporting and, you know, who knows who's told what about their health.
Okay. Kathy Raleigh has a question or a comment. Kathy?
Hi, good morning. I just wanted to comment on
the conversation around the Burfus data, the survey, the sample survey, and the differences, the clinic data, possibly getting that. It sounds like that if we were able to get the clinic data, we're thinking that it could give us a bigger picture of what's happening for the asthma rates. I do know, I mean, what we know obviously with Burfus data as 18 plus population, that it is representative of the population. And I think some of the clinic data, we could look at, I don't know if it's been mentioned before, but the APCD data, the all payers claims data is possibly a way. I know it's trickier data, but that is one avenue to get a broader picture of clinic data, which would be different. But anyway, I just wanted to throw that out there that, that those differences probably exist within that. But there are other avenues possibly to get the information.
Yeah, well, I'd like to move on with this presentation. I can tell you that I have talked to the people at the health department that are sort of in charge of being gatekeepers to all payer claims data. And yes, I would really like to get those data. At the moment, we don't have the staffing capacity required to get those data. We need somebody with an expert level of ability in SAS and background in medical billing. And those are sort of the baseline requirements. So let's just say I haven't given up, but it's not going to happen fast. Could I have the next slide, please? So this is a look at Black student data. And this again is from the Minnesota Student Survey. And it's similar to the earlier stage for the Latino Hispanic students in that it breaks down students by country of origin, except this time it's looking at African Americans. And I think it's really interesting to see where the students that indicate country of origin in Africa rank relative to other Black students. The African Americans, i.e. those born in this country, are more likely to report having been told they have asthma than any other subgroup represented. So this gives rise to several questions. We hear about the healthy immigrant effect. Is that what we're seeing here? Or are immigrants less likely to have access to healthcare and thus less likely to be told by a medical provider that they have asthma? And then the other question that I've had is, in recent years, Africa has been a primary source of immigrants for Minnesota. And I've been trying to get the numbers to look at this and haven't, of course, gotten the numbers that I want. But they've comprised between 2009 and 2011, 19% of immigrants to Minnesota were from Africa. And when you're talking about a population of less than 400,000, which is the number of African Americans we have in this state now, if you get an influx that's fairly large, it may start skewing your numbers. So even though I was really excited to see that little downward trend, it's possible that the people that we've been concerned about for a long time, which are those African Americans who were born in this country, it's possible the rates really are not declining for them at all, and they're just being diluted by this healthier group that comes in. Just a lot of questions around these data. Next slide, Kelly. And now moving away from race and ethnicity, we're looking at emergency room visits, and these are the data that Kathy Raleigh works with. So this first slide shows the counties with the highest rates of asthma-related emergency visits in 2019. And you'll see that whereas the state on average is about 34, we've got Mille Lacs, Ramsey, Kennebec, and Mahnomen that are all roughly 50 and higher. I chose to break it off at 49 with Mille Lacs instead of going down further, because then there's a jump down to 42. So these are really 4 counties that are just higher than other counties in Minnesota. And I've circled the counties in red, if you can see that on the map. And then I kind of copied the distribution, what it looks like, the shape of it. Next slide, Kelly. This shows the emergency room visits for the metropolitan area. Again, this is from the data that are available on the Public Health Data Access Portal, which is what Kathy Raleigh works with. And these show the metropolitan area zip codes with the highest rates of emergency room visits for asthma. Again, if you look at the state, it's about 34. If you look at the metro area, it's about 39. And then these 5 zip codes are way up there. Again, there was a pretty distinct drop after the 154.6, which is why I chose to show these 5 zip codes instead. And these zip codes are represented kind of by the darker green area, but doesn't really show you enough detail. Essentially, we've got a couple zip codes in North Minneapolis, and then 2 more zip codes that kind of come around the bottom of the Minneapolis area to the south. So these are the areas we should be focusing on, you know, to really respond to disparities. And then next slide, Kelly. This last slide shows ER visits for patients ages 0 to 17 in the 9 metro area zips with the highest visits. So I thought I'd just add this to provide a little more data. And that's it for the data presentation today. I hope that at least it gives you an idea of what our disparities are and where we should be focusing our efforts. I guess I'm up next. So next up, we'll just talk about our action steps.
Not sure why that. Do you guys see the emergency room visit slide in the middle there? I'm not sure why, but. Okay.
Yeah.
All right, I'll just do, sorry about that, Anne. Just move ahead. Not sure why it's there.
So this slide underneath the other slide shows the asthma care goals we came up with for the strategic plan, and they involve advocacy, partnerships, data, health equity, healthy environments, asthma management, and systems change. Developing the action steps actually took a little more work. We had, next slide, Kelly. We had some goals we set out to meet when we started working on the action plans. And part of this was because when we did the surveys, when we started this development process, we learned that hardly anybody had read the plan. Although everybody thought we needed a plan, nobody read it. So we were trying to create something a little more interactive, a little bit shorter, and we wanted steps that could engage everyone. So last time we had about 95 action steps. This time we've cut it down to 10. And then another thing is we know that many factors influence whether asthma is controlled, which is good news, and that it means there are many actions you can take to try to get a hold of asthma. So our second criteria was to develop action steps that engage people across sectors. So not just medical professionals, but also people working in housing regulation, people who build the places we live, work, and learn, and people that work to reduce pollution and create green space and safer communities. So essentially, we are all stakeholders in this, whether directly or indirectly. And then finally, because we're all in different positions, we have different resources and different capacity, we wanted action steps that could be adapted to everybody. Whatever your situation, whether you're going to be acting individually or you're leading a large organization, we want some action step that you could engage on. So those were our goals, keeping the list short and encompassing multiple factors and adaptable to any situation. And after a process of working through ideas people sent, trying to write them up as action steps, and then actually taking a vote. These are the steps we ended up with. The first 3 steps relate to empowerment and equity. And these are including the voices of people with asthma in healthcare decisions and advocating to equalize social and political determinants of health and engaging communities with asthma disparities. Next slide. The fourth and fifth action steps sort of can be grouped as guidelines-based care. So for these steps, we would ask that healthcare providers educate about guidelines-based asthma care and that their asthma care guidelines are embedded in protocols. Next step, I'm sorry, slide. Steps 6 and 9 sort of relate to policy. So add partners who can promote systems and policy change, and then diversify and expanding funding to bring about policy change. Next slide. And then our last 3 action steps are 7, 8, and 10, which relate generally to the environment, reduce smoking, protect workers and occupations at high risk for asthma, and support clean environments. So those are the action steps we'll be working with in our breakout rooms today. We know that all of you that are at this meeting work hard to make lives better for people with asthma every day. And because of your interest and your connections and the respect you've earned from your colleagues through your work, we're asking you to help us promote this plan by trying to engage your organization and contacts in taking just one step toward better asthma control in Minnesota. So next up, we have a demonstration of the interactivity of the plan from Kelly.
Oops, sorry. Okay, I'm gonna pull this off. Stop presenting here. Gotta switch something here. Hold on, everyone. All right. Alrighty. Hold on a second. Can everyone see my screen?
Yes.
All right, great. This is the PDF for the Asthma in Minnesota Strategic Framework, and I just wanted to go through this just very briefly. Some of you have probably already been there, I hope so. But when you launch the PDF, you can enter the PDF to click to learn more, and it'll take you right into the table of contents. Now, what Anne was describing earlier is that the strategic framework is interactive, so it's all linked. So this is the table of contents. We have these sections. We have overview, facts, framework, strategies, targets, summary, and notes. This navigation here can also be um, also coordinated up here on the top. This is the top navigation bar, the same kind of arrangement here. So overview facts. So I'm just going to show you a few areas here. So I'm going to click on facts, and it takes you into the facts landing page, essentially like a website. And so you can navigate to the section that you're interested in taking a look at. So I'm going to just click here on health equity, and it will take you into the health equity section. You can actually scroll with your mouse through this section, and you can look at the various different charts and tables and information that we've presented. Say, for example, now I want to go to a different part of the framework, so we're going to click on framework. It'll take you to the landing page for framework, and then you can click on the framework for addressing asthma. So there's a lot of possibilities for exploring and going through the work plan to find what you're interested in learning more about. One of the other really neat features of the strategic framework and that it's interactive is that we have made available a number of external web links. And so if you click here, it will take you actually to an external website. So you can explore more here about the exhale strategies. So that'll take you to that. I'm just going to give you an example here too. What is asthma? Here's another one, what is asthma and how it affects your lungs. You click on that, you essentially go to the MDH website. So take some time, over the next few weeks and, over the next few years actually, to look into this document, um, explore it more. It takes you to some excellent resources. Here's a link to the Minnesota Student Survey. We also have a link to the Life and Breath Report. We also feature our asthma home-based services. There's the the BRFSS, Behavioral Risk Factor Surveillance System. So a lot of different links, a lot of different information. And then when you want to go back to the top navigation, you can click, go back to the overview. You can go to the summary and to our notes. And I just wanted to show you this page. On the asthma notes area, if you click on contact, you can see the information for our asthma program. But if you just scroll up, you can see that, say, for example, someone that wants to receive our Gov Delivery digital communications, you can direct them to this page, have them sign up. You can also get to our website from this area as well. So there's just a lot of really neat features. I don't want to take any more time. I could talk a lot about this, but I just wanted to show you some of the unique features that the plan does offer. So I'm going to drop this off here and go back actually to, does anyone have any quick questions about that at all? I'll just move on to the next part of the slide deck here. So no questions? Okay. All right, there's a few comments. I love this interactive PDF format instead of scrolling through 62 pages. All right, thank you for that comment. That's great. All right, so the next part of our agenda is going to be, Mary, you have a question.
I guess it was just more of a comment. I think that this format is exceptional, and I think it's going to be an easier way for you to keep up with the links and the resources. And I think it makes a great format for other manuals and standards and things like that that need to be published. And I think actually for me to go out and to teach on this or recruit on this, especially in this new position that I have across, Minnesota, I think is going to be a great resource. So nice work.
Thank you, Mary, for that comment. That's great to hear. We appreciate that. So I think everyone can see the breakout room groups activity slide. So I'm just going to talk a little bit about this. I'm going to be just giving everybody some instructions here. So we are going to have breakout room groups now that are being facilitated by MDH asthma staff. There's going to be 3 groups, and they're going to be led by the first group, Susan Ross and Bilkis. Breakout room 2, Anne and Connor, and breakout room 3, Kathy and Emily. See if somebody else is joining. We dedicated 40 minutes to this, but I might have to shorten it here a little bit due to the discussion earlier that we had today, but we'll see how we do. Individual responses are going to be collected using the Jamboard. And Bilkis, if you are available here, if you might put the link into Jamboard for everyone, that would be really appreciated.
Sure, I'll do that. Thanks.
Thank you. And then after everyone goes into their respected breakout rooms and your facilitators move you through the 3 questions. We shared the 3 questions in the agenda previously. You will report out your comments on the Jamboard. So I'm just going to show you that in a few minutes. And then everyone will return to the main room for report outs. I'll give everybody a heads up, like a 5-minute warning that you're going to be returning to the main room to report out. So I'm just going to launch the Jamboard here so that everybody can see this. So breakout room 1 is green, and that's Susan and Bilkis. And as you see up here on the top, there are 2 navigation areas. So when you get in there, depending on what breakout room you're in, you're going to want to go to that section. So for example, I'm going to be with Susan, just as an example, in breakout room 1. And this will be the question, and you will respond on the board. And so you'll go over here to the navigation here, and you'll see the different tools. There's a pen, there's an eraser, there's a select, and then there's a sticky note. And the sticky note will pop up, and I'm just going to write in hi team, whatever my comment is on that question. You're going to save it, and then you're going to post that to the board. All right. You can go up here to the icon, the 3 dots. You can edit it if you want. You can duplicate it, or you can delete it. So I'm going to delete mine because I don't want to have mine on there. So essentially, it's pretty straightforward. You just go to this area right here, click on your note, type in your comment, save it, and post it. So I'm going to delete that and cancel. I'm going to delete that. All right. I'm going to drop this off now, and then I am going to start getting everybody set up to go into the breakout room. So I'm going to ask my colleagues to entertain the group here for a few minutes while I do that. Bilkis, if you have any other comments that you would like to share, and I'm just going to go and start getting everybody set up for the breakout room. So just give me a few minutes.
I just saw Jamila joining us, so maybe Anne, if you want to have some introduction, so that probably would. Yep. Okay.
Welcome, Jamila. I'm sorry to miss well, I guess we didn't introduce everybody. We sent bio sketches, but we would like to introduce you. So could you tell us a little bit about yourself?
Well, can you hear me okay?
Mm-hmm.
Okay, so my name is Jamila. I am a new nurse practitioner. Before that, I was a nurse for 10 years. I'm interested in asthma and wanted to be part of the committee because my kids had an asthma, and I was always going to Children's Hospital for help and all of that. And then I seen the communities who speak Somali, like me, needed more help of learning about asthma and how they can control it. I actually called the other day for an help a patient that needed, because the clinic I work does not have a lot of staff that they can take care of asthma patients, and I didn't know the patient, so he brought his kid who was really asthmatic and having a lot of issue breathing, and I called to ask if for what we can help her with. I called Kelly, if we can help them have a home visit, someone comes to their home and then help them out, knowing what the triggers are for that child, because I look at her health history, and I've seen that she was admitted so many times, and it has to be something that triggering her asthma at home, or her not using the medication proper way, as the family only speak Somali. So I gave him the dad. I educated him for a while and give him the numbers for him to contact. And I don't know if he did. When I called, they didn't answer my phone a couple of weeks back, but we sent him to the Children's Hospital, and I gave him a lot of forms that Kaylee sent it to me in Somali, and went to websites that I can get Somali translated forms, and then I gave it to him. So I believe that helped him because I haven't seen them after. So that's who I am. And this morning I was in a meeting at the clinic too. So I don't have a lot of time to be with you today, but I love to be part of this committee and learn from you, and to help with the patients and the people who speak my language, who doesn't have much education about the backgrounds of asthma and what's causing them to have those kind of triggers, and the places they need to go for help.
Thank you, Jamila. We are just about to move to breakouts.
Okay.
Hopefully within moments, and then we'll all be participating in conversation around 3 questions.
Okay.
Yep, give me a few minutes here. Sorry, I'm working as fast as I can. Room 1, okay.
Perhaps we could explore the questions so you can start thinking about all 3 rooms have the same question of our AAC members. The first is, how will you effectively, as an AAC member, effectively promote and implement strategies listed in the strategic framework? And how can you engage stakeholders and partners in implementing the framework?
Okay.
And I just pasted the questions as well in the chat so people can look at it while Kelly is working on sending us to the rooms.
Yes, and this seems to be the time of year for asthma kicking up for some of us who have seasonal allergies, darn it. The second question is, what challenges can block implementation of the strategic framework? And just as importantly, what are the solutions that we can take, or you can take, all of us can take, to address these challenges, these blockages? And the last one is, what steps and actions will you commit to and your organization commit to in order to implement the asthma strategic framework? Those are the questions we'll discuss in each one of our groups. And then, as she said, we'll put the have you put your sticky notes with your ideas right on the whiteboard as we move through. And we're all new to this, or at least I should say I am, to using it. So please be kind as we we practice this, but you know, practice.
All right, I think I have this set to go, you guys. Bear with me here. So I have the room set up. Hopefully this is going to work. Anne, you have a few more in your room because we had a few people that did not, come today. So I'm going to open up the break rooms. I've set up approximately 25 minutes. Do you want to adjust that at all, Anne? I can adjust it right now. How much time would you like to dedicate?
Oh, I don't give it another, let's make it 10 minutes per question.
Okay, so I'll put it at 30 minutes. And then you guys will come back to the main room. I'll send you guys a warning. And I might pop in and see how everybody's doing here. So, all right, I'm going to open the break rooms and everybody will go in. So here we go. Let's cross your fingers. Here we go. Bye-bye.
Thank you.
And it's thinking. All right, it's spinning here. There you go. I think everyone's leaving. All right, Jamal, I need to send you into a breakout room here.
Where do I?
Are you going to be, I'm going to, hold on a second. I'm going to stop the recording here too. Okay.